Hello there. If you were unlucky enough to stumble upon this video, then just give it. I had a very unlucky storage related accident, so I'm just trying to find a place to store my recordings. And sorry again, just skip it. Now, when we talk about hand anatomy, okay, one way to look at it is by dividing it into its main components. Now, the hand is composed of the bones, joints, ligaments that would give the hand its integrity, the tendons and muscles that would move those bones, the arteries, veins, lymphatics, and nerves, and the soft tissues that connect all of those things together. So it seems easy or easier to look at the hand from this perspective. Now, starting by the beginning, we would look at the bones and joints of the hand. Now, now, first of all, now simply the hand is composed of the carpals, the metacarpals, and the phalanges. Again, an easy division of the bones of the hand. Now, functionally, however, we must include the radius and ulna, at least the distal part of the radius and ulna, which together with the proximal carpal row form the wrist joint. Now, this is not exactly right because the direct contact, as you can see in this image, is between the distal part of the radius, okay, and the scaphoid and the lunate. Okay, this is the scaphoid, this is the lunate, and this is the distal part of the radius. A few points to mention about the radius. First, it is sloped. Okay, you can see the difference between the radial part of the radius and the ulnar part of the radius. Again, um, it's also sloped from the dorsal to the volar aspect. Okay, 2212 the slope. The second thing about the radius is that it not only moves in in flexion and extension, it also moves in pronation and supination. It just turns around the ulna. Okay. Now, as we know from flaps that any rotation would lead to proximal translation. Okay, and this is why the initial position of the ulna relative to the radius is important. Okay, if it goes beyond its supposed position, it might lead to impaction and what's called positive ulnar variance. Okay, if it goes too short of the radius, the forces transmitted through the wrist might be transmitted only through this part. Okay, mainly to the lunate. This is the radius and this is the lunate, leading to repetitive trauma to the lunate, leading to avascular necrosis and Kienbock disease or other diseases. The other thing about the ulna is that it is actually a part of the wrist joint. And the way it is mainly, the main way that it is connected to the wrist is through what is called the triangular fibrocartilaginous complex. Okay, now it's complex because it's composed of many structures. Okay, 7 structures to be exact. The first is the triangular fibrocartilaginous proper. Okay, this is the meniscus-like structure. Meniscus-like in that it has poor vascularity and thus it has poor wound healing. Okay, surrounding it there are the radio-ulnar ligaments, one dorsal and one palmar. Okay, forming the palmar radio-ulnar ligament and the dorsal radio-ulnar ligament. Unintuitive, I know. 3 ligaments connect the ulna to the carpal bones, namely the capitate, the lunate, and triquetrum, called the ulnocapitate, ulnotriquetral, and ulnolunate ligaments. And finally, with the extensor carpi ulnaris subsheath, okay, this is the triangular fibrocartilaginous complex, which forms the main part of the connection of the ulna, besides the bony attachments between the distal radius and ulna, which is responsible for about 30%, 20 to 30% of the stability of the distal radial ulnar joint. Okay. Now there are other ligaments of the wrist. However, uh, one ligament or 2 ligaments actually that I want to talk about is the or are the distal intercarpal ligament and the dorsal intercarpal ligament and dorsal radiocarpal ligament. I want to talk about them because they are somewhat beautiful because they form a V shape with its apex being the scaphoid ligament, the scaphoid bone, sorry, thus allowing the mobility of the wrist without affecting the stability of the scaphoid. Okay, which is Seems like it's beautifully engineered to have this effect. Moving on to the scaphoid, the proximal carpal bones. The scaphoid bone, someone saw this bone and decided that it looks like a boat and thus called it the scaphoid bone. Now, the things about the scaphoid first is the fractures. Okay, now the vascularity of the scaphoid bone is unique in that despite it receives blood supply from both the radial and ulnar artery, they both come from the distal part. Thus, with the fractures, the proximal part might have poor vascularity and vascular necrosis, which is somewhat frustrating, especially that the scaphoid is the most common bone to be fractured of the carpal bones. Okay. Now, the second thing is the tubercle of the scaphoid. Now, this part is the tubercle of the scaphoid. If you look at your hand, okay, moving on into the distal crease of the forearm, okay, palpate the flexor carpi radialis, radial to it, you can feel a bony prominence, okay. This is the scaphoid tubercle, okay. Now, each of the fingers should point at the scaphoid tubercle, okay, with flexion. This might serve as an indication for the proper rotation or more rotation of fingers in case of fractures. Okay. The second part about the scaphoid is the scapholunate ligament. There is another ligament, the lunotraquetral ligament, which are very important for the stability of the carpus and thus the wrist joint. Okay, and their injury might actually lead to instability of the wrist joint. Okay. The other bone is the lunate. Again, someone saw this one and decided that looks like a moon, maybe in X-ray, I don't know. The traquetrum, three-bordered bone, and finally the pisiform, or the P-shaped bone, that is actually a sesamoid bone within the substance of flexor carpionaris tendon, and it is the only bone that is attached to a tendon or muscle directly of the carpus. Okay. The other thing that we should know is the Brula's lines. Okay. Now, the way the proximal and distal carpal bones are organized is in a beautiful way that would allow those smooth lines to be drawn. Any disruption of those lines might indicate fracture or a disruption of the aforementioned ligament or any other ligament of the carpal bones. Okay. Moving on to the distal carpal row, we have the trapezium, a very important bone with the anastomosis of the first metacarpal. Okay, you can see it has a unique anastomosis with the first metacarpal. That's the double saddle. Okay, you can see the double saddle attachment, important for the mobility of this of the thumb. Okay, the second one is the trapezoid. Okay, then the capitate, which is the cornerstone of the distal carpal row, and it's the largest of the carpal bones. And finally, the hamate with its hook, as we can see later on. Moving on, okay, the hand might be looked at from another perspective, from another functional perspective, to be composed of 4 units. Now, if you put your hand like this gentleman, you would notice that there is a fixed part, okay? This is the fixed part. And all of the other components of the hand seems to be rotating around it. In fact, if you put an arrow or a pen or anything through the apex of this cone, okay, it would point into the metacarpophalangeal joint of the middle finger, which is the anatomical midpoint of the hand. Okay, this is because the hand might be divided from a functional point of view into a fixed unit. Okay, the blue area here, which is composed of the distal carpal bones and the second and third metacarpal. It is fixed. Okay, it moves as a single unit. Okay, by the aid of flexor carpi radialis, extensor carpi radialis, longus, and brevis, with brevis being the most important. Okay, and 3 mobile units. The first is the thumb. Okay, the second is the index phalanges, and the third, well, basically the rest, the phalanges of the middle finger, and the metacarpals and phalanges of the fourth and fifth fingers. Okay, now when we talk about the thumb, okay, the highest mobility of the hand comes from the metacarpal ligament, joint. Okay, as I've mentioned, it's a double saddle joint. Okay, as you can see in this image. Okay, now it allows a great degree of movement. Okay, cultivating in circumduction and even distraction. It can allow up to 3 millimeters of distraction. Now, this high mobility comes at the expense of stability, like in the shoulder joint, for example. Okay, this is why the carbo-metacarpal ligament or trapeziometacarpal ligament needs the muscles of the hand, namely or mainly the adductor pollicis and the first dorsal interosseae, and ligaments to maintain stability. Okay, now if you see this part, okay, or I have a clearer image. Okay, this part, it seems like a peak. Okay, from this part, okay, there is a ligament that connects the first metacarpal to the trapezium. It's called the beak ligament. Okay, another ligament is the dorsoradial ligament and posterior oblique ligament. Okay, along with the intermetacarpal ligament connecting the first and second. All of those are important for the stability of the thumb. Okay, now the second mobile unit is the index or phalanges of the index. Now the rest, while this part is fixed, okay, this is not, and it allows some degrees of flexion. In fact, if we look at it from the other part of the hand, okay, we can see like the difference at the level between the fifth metacarpal and the second metacarpal. Okay, it seems like the whole hand trying to move or rotate around the fixed unit. This is actually lost in ulnar nerve injury in what's called, if I do remember correct, Macy's sign, and you can see it. You can see higher level of the metacarpals. Okay. Again, the thumb. Okay, we talked about the trapezium. Okay, and the metacarpal. Okay, and the carbo-metacarpal joints. Now there is a functional image, okay, that's actually not supported by evidence, but they think that the distal phalanx resembles the distal phalanx of the index finger, proximal phalanx of the thumb resembles the middle phalanx of the index finger, the metacarpal to the proximal phalanx, the trapezium to the metacarpal joint, and the scaphoid to the capitate. Okay. Now again, it's just a functional view to explain the function of the hand. It's not supported by clear evidence, as I've mentioned. Then we have the metacarpophalangeal joint. Okay. Now, while there is a higher degree of mobility for the metacarpophalangeal joint of other fingers, the metacarpophalangeal joint of the thumb allows the least mobility in comparison to the others. Okay, now the other metacarpophalangeal joint. Okay, and this is because it needs to provide stability. Okay, now the mobility we have got from the trapezium metacarpal, but the stability from the metacarpophalangeal. Okay, the important points that we need to know about the metacarpophalangeal joint is first, its collateral ligaments are taut in all directions, so it does not allow the abduction or adduction. Okay, adflexion or extension. There is no cam effect like the other fingers. There are two sesamoid bones on each side of the flexor pollicis longus. Okay, and there is a volar plate in this part of the finger. Okay, moving on into the proximal phalanx. Now there is something about the connection between the proximal phalanx and the distal phalanx, the condylar configuration, that with flexion there is a slight rotation. Okay. Now moving on to the motion of other fingers. The metacarpophalangeal joint, okay, allows 0 to 90 degrees of movement. Okay, the distal interphalangeal joint allows 30 to 90. That is 30 in hyperextension to 90 in flexion. Okay, the proximal interphalangeal joint allows 5 to 110. Okay, 5 hyperextension, 110 of flexion. Okay, so the greatest flexion is the proximal interphalangeal joint. Okay, and the greatest extension is in the distal interphalangeal joint. Okay, now the unique thing about the metacarpophalangeal joint, okay, is that it allows some adduction and abduction. Okay, especially when it is extended because of the cam effect. Now you can see there is a difference between the how tight is the collateral ligament at flexion and extension of the joint, which is logical because when I open my hand, okay, wanting to grab something, it is more logical that my fingers would be allowed to take more space to surround the thing that I would want to catch. Okay. However, upon closing my hand, like holding a hammer, for example, I would want them to be stable to stabilize the thing that I'm holding. Okay, so this is the cam effect, okay, which result from the difference in the length of the collateral ligament in both directions. Okay, now the other thing about the metacarpophalangeal joint is that the stability of the joint not only depends on the collateral ligament, but actually on the dorsal interossei. So if we lose those collateral ligament, the stability in case of the ulnar nerve is okay and the dorsal interossei are okay, the stability of the metacarpophalangeal joint is also maintained. Okay, now this is unlike the proximal and distal interphalangeal joints in which the collateral ligament are the only stabilizers. Okay, now the other thing about the metacarpophalangeal joint, you can see the diaresis here for the collateral ligament attachment, and you can see the hinge joints of the proximal and distal interphalangeal joints allowing only flexion and extension. Okay. Now, metacarpophalangeal joint, as we have mentioned, allows circumduction also. The volar plates, another thing that we want to talk about, is present at the metacarpophalangeal joint and the interphalangeal joints. Okay. Now, in the metacarpophalangeal joint, there is a connection between the flexor part and the extensor part. Okay. This is the volar plate, and this is the extensor connected with the sagittal band. Okay. Finally, we have the chacrine ligament. Now, chacrine ligament, some books like Nelligan in the Introduction of the Anatomy insist that they are pathological structures, that they are not present in normal hand. Okay. Other places of Nelligan and other books say that they are present, but they might have a pathology. Either way, the lateral volar part of the proximal phalanx is called the assembly line, which is where the flexor sheath, the cleland and racing ligaments, okay, connect. Okay. Now, ideally, the volar plate should not be should not be attached or should have no connection with this assembly line. Okay. In case of fibrosis, in case of contractures, it's attached through those chacrine ligaments. Okay. Okay. Finally, this is a beautiful image. Okay, in which you can see the A. This is the location of the impacts. Okay, now of the radius and ulnar during pronation mainly. Okay, B is the hook of hamate. Okay, C and D is the difference between the metacarpophalangeal joints and the interphalangeal joint. Sorry. Now the thing I want to talk about is the ulnar deviation of fingers. They are not straight. Okay, but there is a deviation about 15 degrees. Okay. To the ulnar side, which would contribute to the ulnar deviation in arthritis or something like that. I think this was supposed to be a thank you or references, mainly Graf, 7th and 8th edition, Essential Third, Mulligan, Moore, and I don't think there is anything from Secret. So thank you very much.